today we're going to talk all about bone marrow transplant and essentially what's involved in that. So I'm really excited because we've got a great panel with us today. So I'm keen to get started because I want us to have a good amount of time to have a good discussion and answer a few questions. So I'll just start by introducing myself briefly. So I am the Advocacy Officer at Leukaemia Care. But as well as being the advocacy officer, I'm also a former patient. Some of you might know me if you've chatted to us before, but I've previously had ALL and I've also got experience of having a stem cell transplant myself. So a lot of the questions that we'll be covering today will have been questions that I've had myself and that I know that a lot of people have too. So I think, yeah, we're going to have a good session today. So just a small amount of housekeeping before we start. Please feel free to put any questions that you've got into the chat. The function on Zoom should be enabled, so you should be able to pop them in there. And also, if you're watching on Facebook, please feel free to put them in the comments, and someone from the team will be collecting those and feeding them back to me on my FAQ sheet. So I'll hopefully cover as many as I can. But if anyone has any questions after the webinar, then please do feel free to get in touch with us to go through them. So I'll start by introducing the rest of my panel. If I could start with you, Rachel.
Hi, my name's Rachel and I'm the External Affairs Officer at DKMS, and we're really excited to be partnering with Leukaemia Care on this webinar tonight, and look forward to telling you more about what we do and our involvement in the stem cell transplant process. So thanks for having us. Thank you.
Sandra, would you like to go next?
Hi everyone, I'm Sandra Giovanna Salamanca Pinzón, and I am Search and Registry Coordinator at DKMS Registry in Germany. Yeah, and I'm very happy today to be here. I'm really excited.
Oh, thank you, and we're really happy to have you. I know that you're sitting a little bit ahead of time for us, so we're really thankful that you could join us today. And next I'll go to Angela, please.
Hi, thanks Sophie, and thanks for the invitation to be joining you on here. I'm Angela Leather and I'm the lead nurse for cellular therapy at the Christie. I've had 21 years experience as transplant coordinator and I'm currently leading that team now. So thank you again.
Oh, that's brilliant. Thank you for joining us today. And I think this is a good opportunity to introduce Adrian. And Adrian, if you'd like to introduce yourself, and you can go straight into your presentation for us, if that's okay.
Yeah, hi, I'm Adrian Bloor. I'm a haematologist at the Christie Hospital in Manchester. I work with Angie, and I'm the stem cell transplant director, have been for the last 15 years or so. So I'll try and share some slides. So as I said, I've been the transplant director here for a while. Having a transplant's a daunting prospect, and I think that it's something that I remember when I first started doing haematology in 1990 something, and the first time I saw someone having a transplant, I started as a junior doctor, and they came in on the day I started, and they were still there on the day I left 6 months later. And I thought, what on earth is this all about? This can't be how it works. And it's very easy to get a very skewed view of transplant. And it's important not to forget the fact that actually this can be a really effective treatment. Next slide. So what I wanted to just share, this is a patient. Next slide, Nick.
Apologies, I'm now having problems sharing.
You're shared, but not progressing.
Yeah, it's not clicking through for me. Ah.
Here we go. So this is just a journey, a patient journey, and this is a real case. So this is a patient of mine called, and he's Danny. I don't think he'd mind me telling you that's what his name is. He was referred to me with acute lymphoblastic leukemia. He'd been treated with chemotherapy, it had worked, and then unfortunately he'd had a relapse. And this was at the end of 2016, and he was referred to me for some chemotherapy and a transplant. And what this slide shows is three things. One is his white blood count over time. So this is just a marker of how he is and what was happening. So normally running between 4 and 10. The three orange squares represent his times in hospital, and then the green triangles when he was on immunosuppression. So the first orange rectangle. He was inpatient for a few days. He had some chemotherapy at the beginning of 2017, which I was pleased to say was successful, and he went back into remission. He was then admitted about a few weeks later for his transplant, which was the second orange rectangle. So he was an inpatient for about 4.5 weeks, and he started immunosuppression in green. He took that for a while. It took it for 3 months, and it was then tapered over 6 months. He had one admission in May 2017 for 5 days with an infection. His blood count then normalized gradually over the remaining course of 2017, and he's never been in hospital since. I used to see him like once a week because I did that with transplant patients. And after a few weeks, when absolutely nothing had happened, said, well, let's see you once a month. And then it went to once every 3 months, and he has been absolutely fine since. He comes to see me now once a year. He's currently living in Colombia. I don't really see him very much. He's doing really, really well. He's in remission. He has no graft versus host disease. He has no infections. He has a normal blood count. He's got married. He's bought a house, and he's getting on with his life. I tend to see him at the end of the year. Next slide. The reason for that is a self-serving thing, because it comes up to Christmas and he always buys me a bottle of wine. So it's been a good thing for both of us. So I think the important thing, and with all the things you'll read about transplants, and when you read information, it is like chemotherapy information, it is a huge list of toxicity and side effects. But don't lose sight of the fact that actually, when you're in and having it and you speak to other patients and you come to clinic, you see gloom and doom. And actually, the patients I don't see are the ones that are doing really, really well, and they exist. And I think that's an important thing not to lose sight of. It's not perfect, but it does work. Next slide. So in terms of why does a transplant work? Why do we want to do it? And why is it better than chemotherapy? Why would I have a transplant if my chemotherapy has failed? And the reason for doing it is there's a complex interaction between your immune system and cancer. So this is a schematic, this is a cartoon that demonstrates, people say to me, why have I got cancer? Well, there's a constant battle between your body, which is making abnormal cells. So this is shown that, that we make 10 billion white blood cells every day, and some of them are always going wrong. And normally speaking, as in A, your immune system, which is shown on these this is shown for a solid tumor. So the black cells are the cancer cells, and the round circles are your immune cell. They will overcome it and get rid of it. What can happen, though, is that the tumour finds some way to evade it. And sometimes for a period of time, it sits in an equilibrium. The cancer's there, the immune system is trying to get rid of it. And sometimes it works and sometimes it doesn't. But what can happen is that the immune system is not able to evade, to control the tumour, and the cancer wins and it develops. And so the aim of a transplant is to reset what should be happening, harnessing the immune system to reset your immunological reboot. Because if you have a transplant, you have someone else's bone marrow, someone else's immune system, which is never quite the same as yours, and you can utilize that in order to fight to reset what should be happening. So if we go to the next slide, and how I'd like to look at this, it's a bit like a rejection process in reverse. So if you imagine, if you have, as shown on the left, this is a liver transplant, you put someone else's liver into your body, and what happens there is the immune system of your body will try to kick it out. And so you have to take immunosuppressive anti-rejection drugs for the whole of your life in order for that graft to work. What happens with an allogeneic transplant, a bone marrow transplant, is the other way round. By having treatment, you eradicate your own immune system, and then you put a new immune system in. And so it's that kind of rejection process in reverse, the graft versus host disease. So the good bit from that is you're resetting what should be happening, your new immune system fighting your leukemia, lymphoma, whatever it is you've got, and putting back what should have been there before. The downside is that it's quite difficult to separate out the effect that you want, which is the new immune system fighting your disease, from your new immune system fighting your normal tissues, which is what's called graft versus host disease, which is one of the most significant complications of a transplant, and for which you have to take immunosuppressive drugs. Next slide. The key way that this works, though, the key mediators of this graft versus leukemia effect or rejection are T cells. So T cells are part of your immune system. They're lymphocytes, blood cells, and their function normally is to fight infection. And in the context of a transplant, it's those T cells that you inherit from your donor that are the ones that will be, they're the effector cells. It's those cells that will hopefully prevent the cancer, prevent the leukemia, prevent the disease coming back again. But too much of a good thing, too many of them, and that can then lead to problems, as I said, with graft versus host disease. And so you need to take drugs in order to damp that down, to have enough of the effect that it controls the disease, but not too much of it that it will cause unacceptable complications. So next slide. What's involved in having a transplant? There are 3 steps to having a transplant. The first is you need conditioning. You need to have some treatment which will allow your body to accept the new immune system. If your immune system works and you just have some stem cells, then your body will kick it out. It wouldn't do anything, it wouldn't work. So you have to have treatment. Now, some people will get a lot of treatment called a myeloablative or full intensity treatment. That's a kind of blunderbuss therapy, predominantly for young people, whereby you have a treatment which both suppresses the immune system and also can work quite effectively to suppress residual leukemia or residual disease. But most people who need a transplant, most people with blood cancers are not of an age where that is really practical or deliverable, and so they have reduced intensity therapy. And the aim of that is not to put the disease into remission, it's to prepare your body to accept the graft. You don't have the transplant, and that's a bit of a non-event. We've had people that come and try and film it, and it's just like having a blood transfusion. It's a big deal. It can feel like a very important day, and it is a really important day, but really nothing very much happens. You sit there, a bag of cells goes in, and then 10 minutes, 20 minutes later, it's all done. That's the transplant done. Then your blood count goes down because of the effects of the conditioning, and you wait for it to come up. And during that period of time, you will need some immunosuppression because you have to control those T cells. So it's different having chemotherapy. And there are different drugs that can be given: cyclosporin, tacrolimus, mycophenolate, a variety of things. Different protocols will have different drugs applied to them, but the aim of them is to allow the transplant to work. And you won't have to take them forever, because unlike having a kidney transplant where your body will try and kick it out forever, it's something that you only need to take the immunosuppression for a period usually of a few months. But the other important thing is that you may also need to have some more treatment afterwards. So you get the transplant to work, the new graft is working, but depending on what happened, then you may need to have some additional T lymphocytes afterwards if it hasn't quite achieved the desired effect. And that doesn't mean the transplant hasn't worked, and that can go on for many months afterwards. And that's something you have to discuss with the person who's doing the transplant, but it is a multi-step process to having it. Next slide. Who can have a transplant and when does it work? Well, there's 3 real things. When do you get to a transplant? It's a means to keep you in remission, not put it there. So you need to be in remission first. So you'll have to have had some chemotherapy to get you into remission. You need to have a good donor, and we've got another talk about that, so I'm not going to talk about that, but you have to have a good donor, and the better the match, the better. And then also there will need to be an assessment of how fit you are in terms of having it, in as much as we can look at how old you are, how fit you are, what other medical problems there are. Now, accepting the fact that most people who have a transplant are not 18 years old and super fit, but nonetheless, we have to take those factors into consideration. When you're thinking about, is it a good idea? Next slide. What are the outcomes of treatment? This is something I talk to people about. Many people, when they're thinking about transplant, it tends to get into a discussion of either I'm going to be cured or I'm going to die. And there's nothing in between. And actually, there are 3 important outcomes. This is important to think about when you're going with a transplant. Transplants can produce long-term remission or cure, because if they didn't, it wouldn't be worth doing it. And as I say, I've shown you an example of when that can happen. That's why we do it. Because of the complications, particularly infection or graft versus host disease, a proportion of people having a transplant will not come through it. And that risk of death goes on for a long period of time, a year or two after the transplant. But the other thing in between is, and this is something I really encourage people to think about, is it's not just a kill or cure thing. Some people have a transplant will end up with long-term complications of their transplant, or they relapse. And actually, out of those three outcomes, that can be the one that I often think may pay most attention to, because it's got to be thinking, well, you can live either with your disease, but then you've got to think, well, potentially there's an outcome of living with the transplant complications, and they're sometimes not significant. Next slide. It's a bit hackneyed, but it's a marathon, not a sprint. Loads of people sit in my clinic when they're having a transplant. I know I can see it in their eyes, and they go, yeah, I've had chemotherapy. It's fine. You're not talking about me. I'll be all right. Last treatment was great. And then 6 months after the transplant, they finally come around and go, yeah, actually, I get it now. It is a big deal. You've got to set yourself up for it mentally, of thinking the fact this is not 1 month or 3 months. This is probably a year at least in terms of your treatment. Now, some people do brilliantly and they're fine after 6 months. Some people never get over it. Some people have complications for years after transplant. But I would say to you, psychologically, think of it, it's a long journey. And you've got to keep your eye on the prize, because however well motivated you are going into it, 3 months after coming back to transplant, sitting in my transplant clinic in January, having the conversation, how am I doing? Fine. Why do I feel tired? Because everybody does. Can I go on holiday? No. When can I go back to work? In the future. Can I change my medication? No. What's changing today? Nothing. See you next week. And it just goes on and on and on and on and on for ages. And it can be really, really frustrating. But I think that I've got no magic to that, but it's important to know that and then think, right, I'm going to keep an eye on it, because I know at the end of it, I could get better. Next slide. What can I do? And it's really difficult. I think that there's no magic to it. I've seen people who are old and I worry about, who do brilliantly, and people who are young and fit who don't. And I can't always predict it in terms of what happened. But I do think there are some things that people can do. Keeping yourself in good shape is really, really important. Before it, keep fit, eat well, do things. There is no magic food. There is no magic treatment that makes everything better. But common sense health advice, really important. And staying fit, incredibly important. If you smoke, it's a brilliant opportunity not to. Be vaccinated. I'm not a vaccine zealot, but the better your immune system, this will knacker your immune system, and the more you can prop it up, the better, as far as I'm concerned. And the other thing is thinking about practicalities. Not many people can just say, that's it, I can just take a year out and forget the mortgage and forget the kids and my job and the rest of it. And there are no easy solutions. And I think it's really important, though, just to think about that and plan it, and don't be afraid to ask about money and life and what's going to happen with my job, and to be able to, and there may not be great solutions to all of it, but it's important to not have those stresses after the transplant when you're trying to recover from it. Last slide. What's new? Well, transplant's not perfect. The first donor transplant that was done was in 1957, and there have been a lot of advances since then, but we still have, as I said, 3 outcomes. Not everyone comes through it. People still have significant complications. So I think I'd encourage, speak to your team about clinical trials. There are different ways of doing it, changing the conditioning, making it more effective. What can you do to prevent graft versus host disease? How can you manage the complications? There may not be a trial that suits everybody, but I think that's how we're going to make progress. You'll hear more in a bit about donors. The better the donor is, the fewer the complications. So it's a real push in this country and around the world to get more donors, fitter donors, better resolution of tissue typing. And there are, if you don't have a fully matched donor, there are alternatives, cord blood, haploidentical. This is using non-fully matched family members I don't have time to talk about, but there are ways of doing it. But I think you need to be thinking carefully about the balance of risks and benefit. And ultimately, my goal of doing transplant would be to never do a transplant. It's a bit of a dirty treatment. At the moment it's here to stay and it can work, but what I hope we will see is that more effective primary treatment, fewer people relapsing and getting to transplant, and maybe more cleverer ways of using the immune system. So you've heard about CAR T therapy, potentially other immunotherapies, which may become alternative to transplants, but not at the moment. And something that, watch this space, but this is something I think for the future. And with that, I will close.
Brilliant. Thank you, Adrian. I think a lot of people will have found that very helpful. I think what you said about it being a marathon and not a sprint is really important to remember and to keep that goal in sight, because at the end of the day, as a patient, you don't know what to expect when you're going into transplant. And I think that's why it's important that we do webinars like this to help people. If there's anyone watching who, you know, transplant is an option or they might have something coming up, then hopefully this will help just to, you know, put a few things in place and plant a few thoughts in there. Brilliant. We've had a couple of questions come through, but I will leave them until we get to the FAQ section. So Sandra, if you'd like to do your short presentation now, that would be amazing.
Yeah, thank you very much. I'm going to try to share my screen now. Okay. Okay, let's see if this is working. Perfect. Okay, so I'm here today to speak about searching for HLA-compatible unrelated donors. I tried to pack this big topic as better as I could for this short presentation. So my goal today is that you understand how the searching is happening. So let's start talking about our human body. My body, and yours too, is made up of cells, trillions of them in fact. Each of those cells contain chromosomes, 23 pairs to be correct. These chromosomes are structures that keep DNA very tightly wrapped. DNA contains genes that determine many attributes in the human body, from hair and eye color to the immune information. When talking about the immune system, we have to include HLA. But what is this HLA and why HLA matters? HLA is the abbreviation for human leukocyte antigens. And what that means? HLA are extremely variable membrane proteins detected by the immune system. They are located on the surface of many of our cells and determine tissue compatibility. Many of those cells in our body have such HLA proteins or markers in their surface. These HLA markers have an impact in the type of the response of the immune system, the specificity, and the strength. In the transplant world, HLA alleles or markers are relevant when talking about histocompatibility, implying recognition, cell communication, and signaling. In easy words, HLA markers are a way for the immune system to tell what belongs in the body and what does not. So how many are they and how many are relevant? The golden rule in blood stem cell transplant considers 10 markers as the most relevant, and it's good to know that there are some others. As they are inherited, we have to have clear that we all have 2 copies. 5 of them are coming from mom and 5 are coming from dad. So the next question is how HLA markers are inherited and what does a match means? Close family members, that means siblings, parents, and children, are most likely to have similar HLA markers. As example, I decided to draw here a patient with 6 of the 10 markers compared to the possible siblings. I gave colors to easily visualize the 2 copies. One of them coming from father here, the blue one piece here, and the other copy coming from the mother, the pink portion here. Theoretically, in each family, there is a 25% probability of inheriting the same haplotype or HLA markers according to the Mendelian rules. This, for example, is the best donor for a patient. This is the identical sibling. There is a 50% chance of inheriting half of the information, and this is the so-called haploidentical donor. There is also 25% probability of inheriting completely different information, although this sibling has the same father and mother. And when do we use this HLA information? Let's see how the path to get into that. All starts with a patient and diagnosis. Our patient here goes to a physician or a healthcare facility and gets a screening. Sometimes this process is very straightforward, sometimes it's a little bit more complex. And when the results are there, the patient is diagnosed. Afterwards, the patient is evaluated and the medical team comes with the indication for a blood stem cell transplant. That means that the patient is a candidate for this therapy, also known as HACT. Our patient here has to decide if wants to continue with this treatment and gives consent for it. As fast as possible, it is required to get to know the 10 markers that I told you. To find out, there is a procedure called HLA typing, which basically provides information about the 10 markers this patient has. With such information, the donor search starts in the family. Some transplant teams run in parallel the search for related and unrelated donors to save time, especially when the likelihood to have a related donor is low. If no suitable HLA match family member is identified, the unrelated donor search comes into the picture. So how do we search for those HLA compatible unrelated donor? And how do we find that person, that stranger out there with exactly the same markers? First, this occurs thanks to the millions of volunteers who are registered. HLA information of volunteer donors is available at the Global Pool database at the World Marrow Donor Association. Most of the donors are registered in North America and in Europe, and most of them, the HLA markers information is in very good quality. That means in high allelic level resolution. Do you remember that I said that at the beginning of the talk that HLA are extremely variable membrane proteins? Well, to place that in numbers, up to date, the Central Repository Database collecting this information has reported more than 21,000 individual HLA proteins. And the question is now how to look and search among all that information. This is happening thanks to several bioinformatic tools using match search engine platforms, allowing us to compare the markers from the patient against the markers of the donors in the database. So less than a third of patients have an identical sibling donor available. This is a global trend toward smaller families. Therefore, volunteer donors are extremely important. Well-matched donors often lack when a perfect matching is crucial. The probability of finding a match unrelated donor can vary between 16% and 75%, depending primarily on the patient's ethnic background. Around the world, there are many organizations facilitating all stages of search and provision of a stem cell source for a patient. Every 27 seconds, someone somewhere in the world is diagnosed with blood cancer, and 4 out of 10 of those patients in the UK, for instance, will not find an unrelated matching donor. This is especially important for non-Caucasian ethnicities. Considering this, there is an urgent need to expand the donor pool to provide adult match unrelated donors for a significant proportion of patients worldwide. So as summary, the search for suitable stem cell source is based on the HLA type of a patient. An HLA identical sibling is considered a donor of first choice. Less than a third of patients have an identical sibling donor available. The availability of a suitable donor represents the key starting point for any blood stem cell transplant decision because patient and donor HLA matching can have a major effect on the success of the procedure. Volunteer donors are extremely important, and for non-Caucasian patients, finding an unrelated donor worldwide remains difficult. So, thank you for your time and your interest. And if you are out there and you haven't registered to be a stem cell donor, please consider that your unique HLA markers could be the exact HLA markers for a patient somewhere in the world needing your help. Thank you.
Brilliant. Thank you so much, Sandra. That was so interesting. As someone who's been at the receiving end of a transplant, there's so much that goes into it. Whereas, when you're in that position as a patient, you're just waiting and you don't realize how much actually goes on behind the scenes. And there's so much that we should all understand about transplants. So again, I'm just so happy to have you here to discuss it with us. Brilliant. Okay, so we've done our presentations now. So we've got a good amount of time to get into some questions. So I think I'm going to start by going back a little bit to Adrian's presentation. So we know that there's a lot involved in a transplant. So what is actually involved in the conditioning and the preparation for a transplant? So what are the different types of conditioning? I know you mentioned that there are, different levels of conditioning, Could you just explain a couple of those for us?
So didn't get into it in too much because doesn't want to sort of get too bogged down in detail. But so it's chemotherapy. I mean, to start off with, so transplants admissions break down into two halves. The first is usually not too bad, and that's when you have some chemotherapy, usually given over a period of about a week, and then you have the stem cell infusion, and then your blood count drops down over the next 2 or 3 days. And actually, that's usually quite straightforward. And that's your conditioning treatment. There's 2 ways instead to do it. For younger people, I say when young, who is young? Well, it's really probably, you can give full intensity treatment up to the age of about 50, but we tend to be anxious about it much above the age of sort of mid 30s and 40s. And that might involve having big doses of radiotherapy, which is for the whole body, so total body irradiation, where you'd have usually 6 or 8 doses of that given over 3 or 4 days, and then chemotherapy as well. Or you might have lower intensity treatment, which is usually quite straightforward. It's often treatment that we're given as an outpatient over a period of about a week. Most people will either have it in hospital. Some places will have ambulatory care, so you can have it out of hospital as a day patient, because as I say, that first period of time usually isn't too bad. You might also have drugs during that time which are to try and suppress your immune system further. So, as I said, T cells are the ones that cause the problem. If you leave all the T cells in, you get lots of graft versus leukemia, or graft versus disease effect, which is good, but you get more graft versus host disease, which is not so good. If you take all of the T cells out, it's really easy to do the transplant. You get no graft versus host disease. You don't get very much graft versus disease effect, and you also get lots of infections because the T cells are an important part of your immune system. So many UK centres, you'll have some treatment either called Campath or another drug called ATG, or anti-thymocyte globulin. These are antibody treatments which are aimed at the T cells. They're not chemo as such, but they're to try and take out some of the T cells. So hopefully you get less graft versus host disease, but you don't take away completely, but you will get more infections. Transplants are balanced. It's like what you do. You can either have lots of infections or lots of graft versus host disease, and it's trying to find a sweet spot. So again, you might have that during the initial period of the conditioning process, and then, as I said, then the next bit is all about then waiting for the new bone marrow, the new stem cells to recover, which generally takes about 2 weeks.
Oh, brilliant. Thank you. Yeah, that's really good. I remember receiving Campath myself, and I always wondered what it was for, so that's helpful to know. Great. So I think that kind of leads into what you said there about the 2 weeks for the graft. It kind of leads into my next question. So if someone has had their transplant, how long is it before you can tell that the transplant has worked or if it's been effective, typically?
So what means does it work? Well, ultimately it's when you're 5 years down the track and you're in remission and it's gone away. But it's like there are just milestones that people go through post a transplant, which we sort of look at, and you've got to go through all of them like hoops. So the first thing in terms of whether it works, I would say, occurs in that period of the admission. Do the blood count, does the transplant work? Does your blood count come back? It might not necessarily come back straight away to normal. That doesn't matter. It can take some time before it comes back to normal, but until it's just like you've got a decent white blood count and you're not needing transfusions anymore. So that's the first step. The second step is often when you get to 1 month, and then we would then look and see how well it was working. We can measure. Sometimes people will have a bone marrow biopsy or a scan to see if their disease has responded. Some people do it at 1 month, others don't. We don't always do it because it's a bit early, but you will do a test often called chimerism. So you can measure in your blood how many of your cells are from you and how many are from your donor. And what you need to get to eventually, ideally, is near to 100% donor cells. So you don't necessarily get there immediately. As I said, it's that thing that occurs over the period of a year. And then we redo it at 3 months. And most people then will have a scan or a bone marrow. We tend to do bone marrows for leukemia, scans for lymphoma. Some people will have both, and then redo the chimerism. And you might then be that you'll have those scans and tests done every 3 months. Some diseases and some centres do things differently, and then a year is a milestone and 2 years is a milestone. And I guess what you want to get to is that everything is perfect, that you don't have lots of graft versus host disease, your blood counts are okay, you're in remission, the chimerism is 100% donor, and that's sort of perfect. You might not get all of that at once, but as I said in the talk, you might also need to have top-ups of cells. So if you got to 6 or 12 months and you're not at 100%, or you've done a scan that shows maybe there's a little bit of disease that's left, then you can add some additional cells. So that's not having a transplant again. People sort of say, oh my God, I've got to come back in. Having donor lymphocytes is really easy. It's an outpatient thing. You just have some cells squirted into a cannula, and then the aim of that is then to sort of get you over the bar. But there's a downside to having that, because it strengthens the graft, and therefore you might get more graft versus host disease. So you've got to think about the balancing risks and benefits.
Brilliant. No, yeah, definitely there is that obviously that element of potentially needing a DLI. That has actually prompted me to look at my questions that we've had. We've had a question on Facebook around a similar topic around DLIs, and someone has mentioned has asked the question, why aren't the lymphocytes from donors kept in case there is a requirement for a top-up of stem cells? Like, is there any chance that during the donor process that is the donor ever asked to donate extra cells, or is it a case of if a patient needed a top-up, then their donor would have to be contacted again, or is it very different for everyone?
Angie probably answer that one.
Yeah, so I think it does vary with the donor and how much the donor is able to donate at the time of the apheresis procedure. So obviously, if a donor donates bone marrow, then we're not going to be able to get the DLI from them. But if we get a big cell dose from the donor at the time of harvest, then we can save some of those cells. So sometimes we do have donor lymphocytes stored in our labs or within the labs, but sometimes we do have to go back to the donor and ask for further cells. So it's a little bit, both of your comments really were right. Sometimes we do have to go back, but if we've got some, we will save them.
Brilliant, thank you. I'm actually going to stick with you, Angie, just for this next bit. I think I want to talk a little bit about sort of the support that you can get during a transplant, because it is a pretty intense time for a patient, and you do need a lot of support, not only from your medical team, but also in terms of mental health and emotional needs and things like that. So as a clinical nurse specialist, will everyone who is going through a transplant be told that they've got a clinical nurse specialist to support them through the process?
They absolutely should do. Obviously, different centres will have sort of like different setups. So the way it works really within our centre is the transplant coordinator is sort of the clinical nurse specialist, but we've also got CNSs as well that are attached to them post-transplant. And I think the role of a nurse specialist is really important to sort of like completely understand what the patient's going through, look at the social circumstances and see what support they require both pre-transplant and after the transplant. And just somebody that they can go to and ask the question. And I know from my previous role is I had patients ringing up and saying, oh, Ange, where's my donor at? Have we got a donor sorted out? And that's one of the most important things. And I think it was probably Adrian that had mentioned, there's a lot of work that goes on in the background that people perhaps just don't necessarily understand is happening. And it takes a while for that to happen as well. So to find a donor can take sort of like 6 weeks or more, really. And I think that's sometimes really distressing for the patient when they've been seen by the clinician. Yes, you need a transplant, and next week we haven't got any further down the line, and it's really quite frustrating. So to have that point of contact to say what is going on is really important. And I think most centres, from my experience, do have that link for the patients.
That's great, thank you. Yeah, it is really difficult when you're told and you're sort of just thrown into this completely new ballpark of treatments and things to prepare for, and not only for yourself as a patient, but also for friends and family as well, to kind of understand what this is, because a lot of people haven't even heard of a stem cell or a stem cell register and things like that. So from your perspective, what is it that how can a CNS help to support not only the patient but also the family to understand what's going on, and how can you help everyone along this wild journey?
I think a lot of it is pointing in the right direction. So, you know, pointing to, you know, peer groups and to social groups to make sure that they've got the information that they require. You know, it is a minefield. What is involved within a transplant? What is expected? What will it be like at the end? You know, at the transplant, and all of those questions that I'm sure that the audience today are asking are really important to ask a nurse specialist or obviously a clinician. But often I find when I was in clinic with the consultants is they would be looking at me for some of the answers as well. So I think there's sometimes that confidence in having a nurse that could speak on a normal level. And obviously our consultants are great, and Adrian's on the call, so I have to be really nice, but they are absolutely fantastic. But I think it's just sometimes having that link after that clinic appointment's finished, to you know, for somebody to go to really, and offering the support. Sometimes, you know, we think we've got everything, but they may need some OT referrals, they may need psychology referrals. So it's actually referring to the right people, and your nurse specialist will be that person that would hopefully identify that and refer on to the appropriate teams so that they're getting that holistic care.
Yeah, I think that's really important, definitely for everyone involved in it, because it's you know, it's a lot to go through, and knowing that you've got people you can talk to, like you say, after an appointment with a consultant, because sometimes it is hard to say to your consultant, you know, well, what happens to my hair at this point, and to talk about fertility and things like that. So it's nice to be able to bring that up to someone else who can also understand and to get those answers. And yeah, because it's hard to know what questions to ask. So.
And I think sometimes it's that understanding when you're in clinic, you know, you're given all this information, and you usually with perhaps a nurse specialist and the consultant, and there's lots of information given to you, but you walk out and you think, oh gosh, what did they say? So actually just that point of contact to just say, look, I had the conversation with you yesterday, and I'm sorry that I don't remember. And that's what we're there for, to just, you know, to just go through it again until the patient understands it, and the families. And again, I've had patients in clinic, and COVID's been really difficult because we've only seen the patient often and not seen the families. So we've had patient families phoning up and saying, oh, could you just tell me what's going on with Joe Bloggs, for instance, because, you know, he can't quite, you know, communicate it to us really.
Yeah, definitely. And like that point about explaining it to other people, it can be hard, and to have that pressure on yourself as a patient, especially during times with COVID and things like that, it must be immense. So having someone there to be able to take that pressure off, whether it's the nurse or, you know, charities like ourselves, like we can, you know, have a chat to workplaces and anything that's helpful to take a little bit of the pressure off, then, you know, every little helps in that sense. But no, that's great. I was just looking, someone has actually mentioned, Adrian, in regard to you made a comment about you know, the sort of questions that you get asked during those follow-up appointments, because they are quite frequent, and everyone tends to get a little bit of itchy feet, like, you know, why are these things happening? And yeah, a lot of questions about the future. So someone has asked, why is it that you can't go on holiday soon after a transplant? Could you just explain that side of things?
Well, you can, of course, do what you want. It's like, you know, no one can stop you doing anything. I think the concern is, so in the first 3 months after a transplant, most people, in order to monitor how they're doing infections and their blood counts and any complications, will often be coming to clinic once a week. Sometimes in the very early period, it can even be more frequently on that, but that's sort of the first 3 months and maybe a little bit longer than that. So it doesn't lend itself particularly well to going away. My concern about going away in the sort of post-transplant period is not so much, it's one is infection. So if you're on a plane, then whatever the airlines tell you, you know, you might pick up respiratory infections. If you're going somewhere that's exotic, then there's obviously other things you can catch. And it's more about what happens, in that I see people who have a transplant, and most people who have a transplant get readmitted for some reason, infection, their kidneys are off, some complication or something, and it can happen quite abruptly. And the problem is that it's fine. You can have transplants in all sorts of places, and there are excellent transplant centres in many countries. It's not, but no one knows you. And if you turn up in wherever, you know, Costa del Sol A&E saying I've had a bone marrow transplant, I think I might have graft versus host disease, it's going to be very difficult and you're not necessarily going to get the best care. I mean, the best one in the world, if someone rings up, I can't necessarily get you home and I can't do something about it. So it's about that proximity to the transplant centre and managing complications. I try and make it least bad. I mean, in the sense that somebody says, I've got a holiday house and I want to go there and, you know, it's in Wales and it's, you know, a couple of hours away. Is that all right? Well, fine. I mean, you know, common sense dictate what's going to happen. Can I go to, you know, on a sort of, you know, holiday? Can I go to America? Well, yeah, if you want to, but you've got to think about the implications of it. What would happen if you got unwell? And people do get unwell. There's nothing that's fixed about a year. Sometimes it's a year, sometimes it's longer. It's like going back to work. And I've said to people, you know, people say, oh, we tend to, you know, the party line is a year. I tend to say sort of 6 months really, but you know, if you're working from home, you can work through your transplant, doesn't matter. And somebody who has a manual job or, you know, farmer or something where, you know, going to be more inherent risk of the infections, then I'm more concerned about it. So it's a dialogue, and all I'd say is just try to sort of, it's common sense. Most of things are common sense, and it's just trying to minimize the risk, because you go to a treatment, bottom line of transplant is I take someone into a transplant knowing that as a take-home figure, there's about 20 to 30% chance of many indications they're not going to survive it. And I know that statistically, and I do it knowingly, because if we don't do it, the outcome's even worse. But I don't want to feel like I'm doing it with one hand tied behind my back. I don't make people come back to clinic because it's for my amusement. It's like everything I'm trying to do is saying, you'll take on a huge risk. Let's not stuff it up. The other question you had asked about was myeloid sarcoma. Just to pick up on that, was the same question. Myeloid sarcoma is a sort of lumpy version of acute myeloid leukemia. And to my mind, it's the same disease. And our transplant outcomes, if you needed it, are fine. So it's not perfect, but for people with acute myeloid leukemia who are transplanted, about 50% of people will have a good outcome, something like that. And it's about the same with myeloid sarcoma. So none of this is perfect, but that wouldn't be something that would make me have particular concerns.
Brilliant. Thank you. Thank you for picking that up. That's very helpful. I'm keen to speak to Sandra and Rachel a little bit more about just have a little chat about the process of finding a donor. Rachel, so when a donor search is happening in the UK, do we look at the entire register all over the world, or do we just look in certain places? How does that work?
We basically look worldwide. Yeah, of course, we are focusing on the UK, for example, for patients from the UK, but we have to have a broad perspective because of those patients, especially those without a genetic background in the UK, for example, those that are non-Caucasians. The probability to find a donor for them has to be out of the country, and therefore we have to look worldwide. Yeah.
Great, thank you. And Rachel, how does it work? If there's anyone watching this who is watching it from the perspective of they don't have leukemia, but they want to potentially help and they're thinking about signing up to a stem cell register, how does it work? Like, what does someone need to do to sign up, and how can they help?
Okay, Fab, thank you. Yeah, so in the UK, there's 3 organisations which who sign people up, but well, I'll talk from the DKMS perspective. So if you want to sign up to be a stem cell donor in the UK with DKMS, you need to be between the ages of 17 and 55 and in general good health. So there's a lot of exemptions, which are all on the website. You can read all about why those are exemptions. But 2 good examples that I can come up with now is that you can't currently have or have had cancer, and you can't have an autoimmune disease such as Crohn's disease. And then there's lots of rheumatoid arthritis and things like that. So yeah, once if you meet those requirements, you can go onto our website. And you can order a swab kit from us. This will come to you in the post, and there'll be 3 swabs in there, and you swab just the inside of your cheeks for a minute, and then you pop them back in to the wallet and send them back to us. We send them to our labs where Sandra and her team do the amazing typing and all the technical things that she's talked about earlier on. And that registers you on the Worldwide Stem Cell Register. So you're ready to be searched by transplant coordinators like Angela, and to when they're looking for people to for patients all around the world. If you are a match for someone, we'll give you a call and let you know the next stage, which would be to confirm that you are a good match, to do a workup to make sure you're all healthy and ready to donate. And then if you get through all of those, we'll make sure you're the best possible match for that patient and you'll go on to donate. And we'll provide all your travel, accommodation, everything, to make sure that you are able to donate. And we can also provide you with money if you have loss of earnings, and we support you through the whole stage of donation. Then we keep in touch with you for 10 years after donation to make sure that you're okay and that your health hasn't been affected by the donation at all.
Oh, that's great. It's really interesting. And I always tell people to join the register because it's so important and it just takes a couple of minutes. And, you know, you might never get called, but on the other hand, you could save someone's life like someone did for me and someone has done for so many other people. So, yeah, it's a really important message. So I'm going to stick with you, Rachel, just for one last question. So if a patient gets to a point where they've had their transplant and it was successful and you're a bit later on down the line, can you ever meet your donor? And if you can, how do you go about doing that?
Yeah, so in the UK, the rules are that you're able to have to meet your donor after 2 years, 2 years after your transplant, but that's on condition of a number of different things. Both the donor and the patient need to be happy to meet and to contact each other. So before that time, you can anonymously send messages to each other. So a patient that would, for example, would send it through the patient team in their hospital, and the donor sends it through us at DKMS, and we send those letters across. And it can't have any identifying data or information in, so that the donor and the patient can't find each other. After the 2-year point, both the donor and the patient will be asked if they're happy to exchange information, and then we'll work with the patient team in the hospital to exchange that information. And then, yeah, you're welcome to chat and meet and talk to your donor and your patient, whichever you are. And we have some amazing stories that you can read on our website about donors and patients who've met. One recently, a patient and donor of ours went on holiday to Corfu together, which is lovely. The holiday snaps look amazing. And we've had others who have flown all over the world to meet their patients, or people waiting to do that now. We have a club of donors who talk to us, and they're also excited to meet you. But it's just, we want to make clear, it's completely up to you. Some donors don't want to meet their patient, and some patients don't want to meet their donors. It's a really emotional experience for everyone, and it's an individual experience. So never feel pressure to get in contact with your donor if you don't want to, but it can also be such an amazing and life-giving experience too.
Oh, that's amazing. Thank you. Yeah, I received a card shortly after I had my transplant from my donor, just telling me that they hoped that I was getting on okay. And all I know is that he's from the UK. So I was reflecting a lot on my anniversary a couple of days ago, just thinking, I wonder if he's thinking about it. So I did buy a thank you card all that time ago, so maybe it's time to write it and to reach out and see if they want to as well. But no, thank you all. You've all been amazing today. So I'm going to wrap things up. I know that there were still a few outstanding FAQs. I'm sorry I didn't get round to all of them that people have asked on Facebook and on Teams as well. But we are running another one. I'll go into more detail in a second, but this is going to be part of a series, so we will be covering late effects and early effects of transplant in another webinar. But Rachel, I'm just going to quickly hand back to you for a second just to wrap up with just giving us a little bit more information about how everyone can get in touch with DKMS if they need you.
Fab, thanks Sophie, and thanks for sharing your experience as well. It's been really great having you. So this first slide, I just want to say, if you're a patient or a family member and you can't find a donor, we're here to help, we're here to support you, and you can get in touch with us with the information on the screen, patients@dkms.org.uk, and the phone numbers there as well. We run campaigns on Facebook, in the press, to get more people to sign up to hopefully find your match. And sometimes, as Sandra talked about before, we can target specific communities if you come from that community and there's not many people on the register. But yeah, the picture up here is of Daniel, who you may have seen in the news, from Northern Ireland. And we ran a huge campaign, and he's just had his stem cell transplant, thanks to finding a donor who came on after we started his campaign. So that's a fabulous story. If you're not a patient, you can and you are eligible to register as a donor, we'd love to have you. This is one of our current patients, Pete. He's been looking for a donor for about 4 years now. And yeah, as I said earlier, you need to be between 17 and 55 and in reasonably good health. You can use the QR code to scan, and that'll take you straight through to our website and where to sign up and find out some more information. Our website also has stories of people who've had their transplants, and we've had stories of donors and donor-patient meets. So if you want to know any more about DKMS, where we've come from, what we've done, that's the place to head. And thank you so much for having us today.
Oh, amazing. Thank you for that. That's brilliant. Okay, so I'll just do my last little bit now, last couple of minutes, just to let you know what's going on at Leukaemia Care and some of the support that we have available. So we have lots of information like these webinars, and also, things like our podcasts and newsletters, and we like to keep everything up to date, and we're always contactable through those channels. So we have got, as I mentioned, we've got some webinars coming up. So our next one in this series specifically is what can help you manage the side effects during a transplant, because as we've briefly spoken about today, transplant comes with a lot of different hurdles and different things to tackle. So that one should be a good session, and that's coming up. It does say September there, but it's actually meant to be, say, December. So sorry about that typo. We also have another one coming up another two coming up in December, sorry. One about employment rights, which I will also be I will be working on as the advocacy officer, and that's in collaboration with ACAS. So a good session for anyone who wants to know a little bit more about that. We've got information booklets. We have ones about stem cell transplants and different types of leukemia as well. So if anyone wants to learn a little bit more about their type of leukemia or treatments, check out the shop. You can order them completely for free to your house, or a download. Support services, we have our helpline and WhatsApp service. I'm often on those just for a chat, or if you need any advice or have any questions. We have our support groups as well, which are very popular amongst patients, because it's always nice to talk to someone who has been through something that you've been through. I know that we do run a few now that are specific to bone marrow transplants, so keep your eyes peeled for that. And we also obviously have our advocacy and welfare service. And we have our counselling fund if anyone is in need of a little bit more support going through transplant and maybe dealing with the after effects as well. So as I mentioned, we run a lot of support groups across the UK and for all different, in all different areas. We run general haematology ones to very specific disease related sessions. So they're really helpful, and it's just a nice environment to come together with people who, again, know what you're going through, and you can just sort of ask each other questions, and it's nice to feel that what you're going through is not, you're not on your own with everything. So yeah, if anyone wants to see what support groups we've got coming up, just give us a call or send us an email to the support email that you can see on the screen, and we can send that over. As I've said, peer support, really important. So the buddy scheme is brilliant. So we can match you up with someone who has got a similar diagnosis or has been through similar treatments to you, and you can call each other for regular support and just to talk about what you're going through, and just to, again, talk to someone who really understands from a very personal perspective what you're going through. So yeah, anyone interested in that, please do get in touch. It's brilliant. Advocacy service, that is me. So there are a lot of things that I can help with and support with. But if you do have any questions about transplant and things like that, please do get in touch again. Like I'm always happy to have a chat with anyone about things like this. But also, of course, our welfare officer is here to help with any financial issues and with grants and benefits and things like that. So all really helpful to know. The counselling fund, we can provide grants for to fund 6 sessions of private counselling to anyone affected by blood cancer, specifically leukemia, MDS, MPNs. So yeah, if you need that extra support, then please do apply for that. It's been found to be really helpful. And of course, we're always looking for people who want to do a bit of fundraising for us. So a little thing that you could do is get one of our tins if you've got a local shop, or if you run a small business, then having one of those could really help. So just get in touch with us today if you want to order one, and we can sort that out. So part of our Christmas fundraising campaign is lighting a star in our night sky, and it's in dedication of anyone who's been touched by a leukemia diagnosis, or anyone who knows someone who's been affected by leukemia. It's a really nice way to post a bit of a tribute to them, and just to write a nice little comment and see your star shining in the sky. It's quite cute, to be honest. So I would recommend having a look at some of the comments on there. If anyone wants to take on a challenge, we do have some quite big fundraising challenges coming up. We've got the London to Paris, and the entry fee is only £125 if anyone's up for it. Could be a good one to do. So yeah, that's always look out for the fundraising that's going on, and we're always running quite a lot of activities, so always helpful. And of course, just keep in touch with us and keep up to date. We're always posting updates and patient stories. So we're online, we're on our website, and we're also very active on social media, Facebook, Twitter, Instagram. So you can reach out to us on any of those platforms. And of course, you can get in touch directly through the helpline, or by giving us an email, or by messaging me on WhatsApp. You'll get through to one of us, and whoever you get through to, we will get you to the right person to get you some support with whatever you need. Brilliant. So I think that's everything tonight, everyone. So thank you all again for joining me today, and thank you to everyone who has watched. If anyone does have any questions after the webinar finishes, then please do feel free to pop an email over, and we will pick them up when we can. Thanks, everyone.